afternoon, one and all. I'll be presenting on sweat source OCT finding in commotio retinae. Commotio retinae is a consequence of blunt trauma. Posterior pole involvement is termed as Berlin's edema, which is a misnomer. The histopathological studies have shown disruption of outer segment of photoreceptors and damage to RP. Few studies have noted that SD-OCT shows hyperreflectivity of EZ and RP. In our preliminary observation, we found that cases with commotio retinae showed hyperreflectivity of outer retina, which was not evident in sweat source OCT. The aim of our study was to describe the SSOCT features of commotio retinae. It was a prospective observational study, and we have included patients who presented with globe injury, presenting within 1 day of injury with commotio retinae involving the macula with clear medium. Color photo and OCT was performed with TopCon DRA OCT. At presentation at 2 and 4 weeks of follow-up, the findings and color photograph were correlated with OCT. The outer retinal reflectivity was assessed with by reducing the brightness of the scan to -5 on enhanced vitreous visualization mode. Here on the left hand side, you can see the OCT image is taken in the normal mode, but the outer retinal reflectivity appears to be uniform, whereas the OCT image on decreasing the brightness, here we can make out the outer retinal reflectivity is decreased on the right half of the OCT image. 10 eyes of 10 patients were included. All were males. Only 4 patients had regular follow-up. The retinal discoloration was limited to parafoveal area in 4 eyes and beyond parafoveal area in 6 eyes. On OCT, we found that a vertical band of hyperreflectivity spanning through the outer nuclear layer was seen in 7 out of 10 eyes, and the band was seen at fovea in all the 7 cases, and there was no correlation with the retinal discoloration. It can be as prominent as seen in case 3, and it can be as subtle as seen in case 4. It was associated with disruption of EZ in 3 cases as shown here. A vertical band, band of hyperreflectivity is in extrafoveal area in 3 eyes, and it was associated with hyperreflectivity of OPL and EZ disruption in the corresponding area. At 4 weeks of follow-up, this is the initial picture of initial presentation OCT image. It showed the complete resolution of the vertical band of hyperreflectivity, and the eyes which had pre-existing EZ loss at initial presentation had a defect at the follow-up. The area of retinal discoloration corresponded to the hyporeflectivity of EZ and RPE in 5 eyes. The hyporeflectivity area on the OCT, as denoted here by yellow dotted line, it corresponded to the area of discoloration on the color fundus image. There was no difference in reflectivity of EZ and RPE, 1 eye as shown here, and in 4 eyes the reflectivity of outer retina could not be assessed as the commotio retinae was limited to smaller area. At follow-up, we found that there was a vacuolar space development at EZ and IZ level at 2 weeks. This is the image at presentation, and here we can see the vacuolar change at outer retinal layer at 2 weeks. Coming to the discussion, the clinical presentation of commotio retinae is transient retinal discoloration. Fundus image of commotio retinae of posterior pole shows retinal whitening sparing the fovea, giving the appearance of pseudo-cherry red spot. It is believed that the disruption of outer segment of photoreceptor is responsible for retinal whitening based on histological studies. Foveal findings were more obvious than extrafoveal findings on OCT in contrary to color fundus image. The retinal discoloration is definitely due to the change in photoreceptor layer as shown by the presence of hyporeflectivity on OCT at presentation and development of vacuolar change at the level of EZ and IZ during follow-up. Though the photoreceptors are denser at fovea, the retinal discoloration is not seen at fovea. So it would be possible that the change in rod pigments are responsible for discoloration, and fovea being devoid of rods may not exhibit discoloration. Retinal discoloration corresponds to hyperreflectivity of EZ on SD-OCT, but in our study it corresponded to hyporeflectivity on SSOCT. This would probably due to higher wavelength of light used in SSOCT. The absorption spectrum of altered pigment in traumatized photoreceptor would be such that it reflects the lower wavelength light better than the higher wavelength, resulting in hyporeflectivity on SSOCT. To summarize, the OCT findings in commotio retinae are lesser than color photo, and the SSOCT shows vertical band of hyperreflectivity in ONL, disruption of EZ at fovea, hyperreflectivity of EZ corresponding to retinal discoloration. Limitation being small sample size, poor follow-up, so the findings seen during follow-up could not be generalized. Most of the findings could be explained by postulate rather than certain evidence. These are my references, and thank you. So as the patient presented within the 1 day of the trauma, the visual acuity, best corrected visual acuity could not be recorded. So we have taken. So the patient who had a complete resolution at follow-up, their visual acuity was normal, but the patient who had an outer retinal defect, the visual acuity was lesser. So,
Whatever you study, this is the baseline of visual acuity should be whatever. It may be PL, it may be head movement, whatever that is the primary component is that's the base of that our any study. Visual acuity, without the visual acuity is impossible to do for any. We are going for higher, but this is some we can give lots of informations, lots of that. Without that visual acuity is impossible for any study.
Sure, sir. I'll try to
for
include
next time
that.
onwards. And you are, of course, you are in a some are you are highlighting then photoreceptor levels, etc. But that this is very much essential for any study. Yes.
Excuse me, sir. Actually, only judges can ask the question. No questions are allowed from the audience.
Okay. As per the instruction. Okay. As per the instruction, he is okay. So his question will not took as your marking,
Yes, sir.
but our question only will be in the file. And of course, if you are selecting why you are mentioning your study is not not correlating with the other study. Can you justify it?
So whatever previous studies were done with the SD-OCTs, so the SD-OCT wavelength was lesser than SS-OCT. And being a higher wavelength in SS-OCT, the findings are different compared to the SD-OCT.
Okay, this is another important point. Second, another you mentioned in discussion slide 1 that your one of the limitation is poor follow-up.
Yes, sir.
So may I know your that follow-up still in all cases?
During the pandemic area, most of the patients did not turn up for the follow-up. So we had a less patients at the follow-up. So.
Okay, but what is your, as on that study, what is your proposed method? In methodology, what is your target for follow-up in such cases?
We followed the patient at 2 weeks and 4 weeks. So as I mentioned, there was a vacuolar change in the outer retina, which we noted at 2 weeks, and 4 weeks. Most of the findings resolved at 4 weeks. So even I think the long-term follow-up is also required in post-trauma
yes, long
cases.
time, yes. In trauma, at least long term. That's why I'm asking. Okay, thank you.